Till we wait for our presenter, I will request Dr. Aqueel Pabaney if he can share his experience. Dr. Aqueel Pabaney, I think you have a presentation, so we can just start the discussion with what you have. And I think the resident that was had to present had some issues, and we're just waiting for his response. And Dr. Aqueel Pabaney, since the participants are here, we will make use of your expertise and your. So you can start with the presentation that you have, and then if the presenter can join, we will take it up from there. Dr. Keel.
Yeah, can you hear me?
Yeah, Dr. Keel, we can.
Oh.
Thank you for coming on board. I'm sorry for today, but I think something happened while the resident wasn't on his way to the hospital. We're not sure, but let's take the opportunity you have. We have you here, so you can share your slides if you can.
Yeah, thank you, Saad, for having me. Thank you. Good morning, everybody. It's actually almost 10 p.m. on my side, but I'm sure you guys are just starting your day, and I hope it's a good one. Thanks for having me here. I see we have a fair good number of crowd here, so hopefully we can try to make this a productive session. I really don't know how the usual format is. I would love for it to be interactive. Because for just like the most of you, we're still young and in the learning phase. Obviously, the learning never stops. I do see Dr. Salman Sharif is here, so obviously we can benefit from his enormous experience. But I would love to share some of although my presentation is fairly brief, and I wanted to keep it very succinct because I didn't want to bore people to to the limit. And just what I was hoping for was obviously having the anatomical lecture precede my talk, and then I have just a few slides talking about the clinical implications of dealing with cortical veins and what to watch out for, because I feel like that's something that most of us, especially during our residency training, don't pay a lot of attention to. And we do talk about superficial and deep venous systems, but superficial veins are basically just for some reason are ignored for the large part. I'm actually looking forward to the anatomical lecture. I'm sure that will be a great overview of the anatomy there, and to go from there. But let me see if I can do this right here. Okay, I'm gonna try to share my screen, and if you guys can see it, please do let me know. And then obviously, can you see my screen now?
Yes, we can.
Okay. Awesome.
Yes, we can.
Awesome. Okay, so I guess what we'll do is, I can start talking, and it's going to be very informal, I believe. Is that okay with you, Saad? And if people want to interrupt or ask questions, or if they disagree with something or have a different experience to share, please feel free to do so. As I said, we're all here to learn, so we want to make this as interactive and productive as possible. So a little bit about myself. I did medical school at Akhtar, and then I came to the US to Detroit to do my residency in neurosurgery. And I spent a year at LSU and Louisiana State University to do a fellowship in open vascular and skull base. Followed by which I actually spent 3 years in practice, where I was the director of neurosurgical oncology and skull base surgery in Ohio. But soon enough, I realized that there is a dramatic shift in management of patients with cerebrovascular disease, and that there's a huge explosion of endovascular arena here, at least in the US and in Europe, where 80% or more of aneurysms, vascular malformations, fistulas are being treated with endovascular technology. As well as there's this huge market for endovascular treatment of stroke. And so I decided to therefore leave my practice and go into training for endovascular neurosurgery. And thus far, thus far, it's been a great experience. And inshallah, sometime when there's, as we move forward, if there's a time to talk about that and that experience, I would love to do so, because I do feel that endovascular is definitely up and coming, and probably an
Hello.
area to be explored in
Uh,
Pakistan.
uh, Dr. Keel, the presenter has joined.
Okay, wonderful.
So I'm sorry for the delay. We had
Oh
issues.
yeah, no. I'll just
Okay.
stop talking
So
and go in the
no.
background.
You saved the show. Because the presenter had issues when he was on his way to the hospital. So now he's here. So
Awesome.
I was supposed to briefly introduce Dr. Pabani, and I think he's done that. Basically, I welcome you all to this session. Dr. Oswin will be presenting superficial venous system of the brain. Dr. Oswin is a fourth-year resident neurosurgery. I welcome our expert panelist, Dr. Aqueel Pabaney, who's a dear friend and a colleague. As he's already mentioned that he is a graduate of Aga Khan Medical School. Then he did his residency from Henry Ford. Then he did his skull base and fellowship with probably Dr. Neil Nanda, and he served for 3 years as the director of skull base and neuro-oncology, and now he's pursuing his interest with fellowship of endovascular. Dr. Oswin, if you can hear me, can you please share your presentation?
Yes, sir. Can you make me host of this Oswin so that I can share my slide?
Imad.
Which user?
Oswin, OSWN.
So Oswin, you're the co-host. Please share your slides. And so Dr. Oswin will present his presentation, and Dr. Keel, we can have your expert opinion at the end. Oswin, please share your slides.
Yes, sir. Yes, sir. Just give me a second. Yeah, this one.
So we can see your slide, Oswin.
Okay, sir. So can you hear me?
Yes, we can hear you, Oswin. Can you move the
Sorry
pointer
for the
so
delay.
that...
Sorry for the delay. So today's topic of discussion is the cerebral veins. So cerebral veins are majorly divided into two groups, which is the superficial venous system and the deep venous system. The superficial venous system drains the cortical veins, whereas deep venous system drains the deep white matter as well as the basal ganglia and the ventricular system. So today we will be discussing briefly about the superficial vein, which is the superficial vein draining into the cortical surface. They collect into four groups of bridging veins. First is the superior sagittal group that drains into the superior sagittal sinus. Second is the sphenoidal group that drain into the sphenoparietal or cavernous sinus. The third is the tentorial groups that converge into the sinus into the tentorium. And the fourth is the falcine group that empties into the inferior sagittal or the straight sinus or their tributaries. So as you can see in this figure, this is the superior cut in which we can see the falx area as well as the superior sagittal sinus running through the superiorly in the falx. This formed the first group of the superior sagittal group, in which there is superior sagittal sinus running, and as well as the we can see the dural sinuses over here, as well as the lacunae which open into the superior sagittal sinus. The second group is the sphenoidal group, which is formed by the cavernous sinus, which get its tributaries from the sphenopalatine as well as the middle sinus, and open into the superior petrosal sinus. The fourth is the tentorial sinus group, which includes the sinus vessels from the tentorial sinus, the transverse sinus, as well as the uh, vessels from the superior petrosal sinus. The fourth is the falcine group, which is not visible over here. We can see in this figure, which is shown in the purple color. This vein runs in the lower margin of the falx, which includes the inferior sagittal sinus, as well as the which communicate with the internal cerebral vein and the vein of Galen, form the falx group, falcine group of the sagittal group. So briefly discussing about the four groups is the superior sagittal group. And the superior sagittal group is composed of veins that drain into the superior sagittal sinus. It includes the veins from the superior part of the medial and the lateral surface of the frontal, parietal, and the occipital lobes, and from the interior part of the orbital surface of the frontal lobe. The sphenoidal group, which include the bridging veins that empty into the sinus that courses on the inner surface of the sphenoid bone. This group formed by the terminal end of the superficial sylvian and occasionally by the deep sylvian veins, drains the part of the frontal, temporal, and the parietal lobe joining the sylvian fissure. These veins drain into the sphenoparietal or the cavernous sinus, or less commonly into the sphenobasal or the sphenopetrosal sinuses. The tentorial group include the bridging vein draining into the sinus coursing in the tentorium, called the tentorial sinuses, or into the transverse and the superior petrosal sinus in the tentorial margins. This group is composed of veins draining into the lateral surface of the temporal lobe and basal surface of the temporal and the occipital lobes. This group include temporobasilar and the occipitobasilar veins, and the descending veins including the vein of Leber from the lateral surface of the temporal lobe. Then we have the fourth group, which is the falcine group. The falcine group is formed by the veins that empty into the inferior sagittal or the straight sinus, either directly or through the internal cerebral, basal, or the great veins. The cortical area drained by the falcine group corresponds roughly to the limbic lobe and a group of convolution that form the continuous cortical strip that wraps around the corpus callosum and the upper brainstem. So discussing about the dural sinuses, which is first is the superior sagittal sinus and the venous lacunae. The superior sagittal sinus course in the midline begin just behind the frontal sinus and grows large as it continues posteriorly in the shallow groove on the inner table of the cranium. It may communicate through the foramen cecum with the vein of the nasal cavity. It drains into the transverse sinus at the internal occipital protuberance through a plexiform confluence venous complex, which is called the trochleohydrophyllae, that connects the superior sagittal sinus, the transverse sinus, straight, and the occipital sinuses. The superior sagittal sinus drain the interior part of the inferior surface of the frontal lobe and the superior portion of the lateral medial surface of the frontal, parietal, and the occipital lobe. So as we can see in this figure, the figure A and the figure B, which is the superior view of the cranium, in which the skull bone is being excised, as well as the dura has been removed in such a way that the cortical vessels can be seen. In the figure A, the arteries are visualized, whereas in the figure B, the veins are visualized. As we can see, the arteries are more deeper than the veins. So as we can see in this, the blue color structure, which is running in the midline, which is the superior sagittal sinus, as and the veins which are opening in this structure are the cortical veins. These are the first is the anterior frontal. As we can see over here also, these are the anterior frontal veins which directly drain open into the superior sagittal sinus, and the blood running through these anterior frontal veins is parallel to the blood running in the superior sagittal sinus, because the course of the blood running in the superior sagittal sinus is toward the confluence. As the direction of the blood is toward the confluence, the blood draining in these anterior frontal sinus is towards the confluence. So it is parallel to in the superior sagittal sinus. Then we have the middle frontal veins. They open directly in the superior sagittal sinus, and they form an angle which is about 90 degree to the superior sagittal sinus. And we have the posterior frontal veins which also open while moving forward anteriorly, and then open into the superior sagittal sinus. In this course, the blood flowing in this posterior frontal vein is opposite to the blood running in the superior sagittal sinus. Then we can see in this figure. The this is the anterolateral view, and this is the superior oblique view, in which this in center structure is this superior sagittal sinus. The And we have on the lateral side we have these lacunae, uh, over here, and the dural sinuses, which and these cortical vessel, which is the anterior frontal vein, the middle frontal vein, and the posterior frontal vein, opening uh, in between, opening directly in the superior sagittal sinus by running below the dural sinuses. They either open directly into the superior sagittal sinus, or they communicate with uh, the dural sinus, and then they direct open and then they open into the superior sagittal sinus. So these yellow arrows are showing that the blood is direction of blood flowing in the superior sagittal sinus is upward. And in this figure, this yellow arrow is showing that the cortical vessels, the blood from the like precentral vein as the postfrontal vein, the blood is in the direction downwards, whereas in this superior sagittal sinus, the blood is running in the upward direction. So this is the in the somewhat different in the cortical vein and the superior sagittal sinus. So in this figure, the figure E, the bone is removed in such a way that the sagittal suture as well as the lambdoid suture is preserved, and we can see the dural attachment with the superior sagittal sinus over here, as well as the cortical vessels, which is the anterior parietal vein and the posterior parietal vein, which is preserved and is opening directly into the superior sagittal sinus. As well as we can see the superior sagittal sinus going deeper into the interhemispheric fissure and forming communication with the transverse sinus as well as the straight sinus to form the confluence, which is the trochlea of heterophyllus. We can see more clearly in this figure F, as we can see the right occipital lobe is being retracted, as well as the left occipital as well as left the dural is retracted laterally, and we can see this straight structure which is passing. This is the straight sinus, and the structure which is in the middle is the superior sagittal sinus, and this horizontal structure is the transverse sinus. So the confluence of this all these sinuses, as well as the occipital sinus inferiorly, the transverse sinus, the superior sagittal sinus, and the straight sinus form the trochlea confluence of the sinus, which is also known as trochlea of heterophyllae. The enlarged venous spaces called the lacunae, they contain in the dural matter joining the superior sagittal sinus. The lacunae are largest and most constant in the parietal and the posterior frontal region, whereas and small lacunae are found in the occipital and the anterior frontal region. The lacunae receives predominantly the drain from the meningeal veins, which accompanies the meningeal arteries in the dural matter. The superior sagittal sinus is triangular in cross section and has right and the left lateral angles at its junction with the dural matter covering the convexities, and the inferior angle at its junction with the falx. The cortical vein may pass directly into the superior sagittal sinus, or they may join with the meningeal sinuses and empties into the superior sagittal sinus. There are 2 to 3 meningeal sinus may join to form a vestibule just before reaching to the superior sagittal sinus. The vein from the medial surface of the hemisphere enter the inferior border of the sinus or turns laterally into the superior margin of the hemisphere to join the veins from the lateral surface before entering into the sinus. So we can see in this figure C, D, and E. This is the superior view in which the bone, the cranium has been removed, as well as the dura has been removed. The middle structure, which is we have already discussed, is the superior sagittal sinus, and around it, which is more on the posterior frontal lobe as well as in the parietal lobe, we can see this blue area, which is the irregular in shape. This is a lacunae. These are the lacunae, which is more clearly over here. These are the lacunae, irregular shape. These are lacunae, which are opening into the superior sagittal sinus. So these lacunae are either directly connected with the superior sagittal sinus, or they combine with the cortical vein and then open into the superior sagittal sinus. So this is the superior view, and this is the magnified view of the superior view in which the dural attachment is also been removed. And this is the lateral view where we can see the bridging veins entering into the lacunae and then opening into the superior sagittal sinus. Here only the bone have been removed, whereas the dura has been intact, and we can see the meningeal sinuses present over here. Meningeal sinus which open, which drains the meningeal veins running across the meningeal arteries, and after removing the dura, we can see the superior sagittal sinus and the lacunae and the cortical veins draining into the superior sagittal sinus. After discussing about the superior sagittal sinus, we have the inferior sagittal sinus, which is the second most largest sinus. This inferior sagittal sinus course in the inferior edge of the falx. It originates above the interior portion of the corpus callosum and enlarge as it courses posteriorly to join with the straight sinus. It arises from the union of veins from the adjacent part of the falx, corpus callosum, and the cingulate gyrus. The largest tributaries of the inferior sagittal sinus are the anterior pericallosal vein. The superior sagittal sinus may communicate through the venous channel in the falx with the inferior sagittal sinus. This connection may infrequently be so large that superior sagittal sinus drain predominantly into the inferior sagittal and the straight sinus. So in this figure, we can see the left hemisphere has been partially removed up to the area where we can visualize the corpus callosum and the area of the inferior sagittal sinus. We can see the origin of the inferior sagittal sinus just above the genu of the corpus callosum, and it is draining, and the anterior pericallosal vein is draining into the inferior sagittal sinus, and it courses directly above the corpus callosum and communicate posteriorly with the straight sinus. So in between it courses, it have the thalamostrial veins draining in, and majorly the drainage is from the anterior pericallosal vein. So after in this figure B, the complete there is complete dissection of the left hemisphere up to where the corpus callosum is completely visualized. In this figure, we can see the posterior pericallosal vein, which opens into the which drains or open into the vein of Galen, which is the great vein, and then open into the straight sinus, where we can also see the vein running below the corpus callosum. Splenium of the corpus callosum is the inferior cerebral vein, which then open into the great vein, and this is the basal vein over here. So the figure B is further magnified over here when we can see the posterior pericallosal vein opening into the great vein of Galen. And then we can see over here is the thalamostrial veins, which are opening into the inferior internal cerebral vein, which communicate with the vein of Galen, and then the vein of Galen open into the straight sinus. In the figure D, we can further visualize completely the structure which we were discussing about the inferior sagittal sinus, which is just above the genome of the corpus callosum, and it is draining the it having major drainage from the anterior pericallosal vein over here. And as it run courses posteriorly, there is also the posterior pericallosal vein, which open into the open into the vein of Galen. And we have over here, this is the anterior cerebral vein, which then communicate with the vein of Galen and open into the straight sinus over here. So straight sinus originate behind the splenium of the corpus callosum at the union of the inferior sagittal sinus and the great vein. It continues posteriorly downward in the junction of the tentorium and the falx. It may drain either transverse sinus, but most commonly drain the predominantly into the left transverse sinus. So in this figure A, this is the lateral view of the post fossa area, in which we can see the cerebellum over here, and this is the tentorium over here, and in between the tentorium is the blue structure, which is running downward posteriorly, and downward is the straight sinus, which then open to the confluence of the which open into the confluence of the sinus or the trochlear of heterophyli. The right and the left transverse sinus originate in the trochlear of heterophyli and courses laterally from the internal occipital protuberance in a shallow groove between the attachment of the tentorium to the inner surface of the occipital bone. The transverse sinus exit the tentorial attachment to become the sigmoid sinus at the site just behind the petrosal ridge, where transverse sinus and the superior petrosal sinus meet. The left transverse sinus usually smaller and receive predominantly the drainage from the straight sinus, whereas the right transverse sinus is usually larger and receive majority of the drainage from the superior sagittal sinus. Thus, the right transverse sinus, right sigmoid sinus, and the right jugular vein contain blood from the superficial part of the brain, and the left transverse sinus, left sigmoid sinus, and the left internal jugular vein contain the blood mainly from the deeper parts of the brain, drained by the internal cerebral, basal, and the great vein. So over here in this figure, this is the posterior view. We are viewing the brain from the posteriorly, where we can see this cerebellum and the cerebrum. Over here, where the superior sagittal sinus is running posteriorly as up to the trochlear of heterophyli, where and over in this figure we can see the superior sagittal sinus is draining into the right transverse sinus, and the left transverse sinus is just below, and its size is also significantly smaller than the right transverse sinus. So from the trochlear of heterophyli or the confluence, the right and the left transverse sinus originates, and it courses horizontally up to where they join with the they curve downward and form the sigmoid sinus on both sides. So in this figure, both of the transverse sinus have been visualized. This is the external occipital protuberance, which is the bony landmark for the confluence of the sinus. And below the bone is the confluence of the sinus, and from there, the both of the transverse sinus, which is the right and the left transverse sinus, originate and courses horizontally up to the area where it turn downward and form an S shape, which is the sigmoid sinus. So this area is the retrosigmoid area over here, which is the asterion, and this area is of very surgical importance because this horizontal structure passing below the bone is the transverse sinus, and at the point of the asterion, it curves downward and form the sigmoid sinus, which is a bony landmark for the retrosigmoidal approach. So in this figure, the right occipital lobe is retracted, laterally, and the superior sagittal sinus is also been retracted. And over here, we can see the structure running downward is the straight sinus. The both on the both horizontal structure, which is the right and the left, transverse sinus, which communicate, which open into the confluence of the sinus, and the superior sagittal sinus also open into the confluence of the sinus, which is the area of the trochlear of petrophyllae. So other sinus are the tentorial sinus. Each of the half of the tentorial has two constant but rarely symmetrical venous channel. The medial and the lateral tentorial sinuses. The medial tentorial sinus are formed by the convergence of the vein from the superior surface of the cerebellum, and the lateral tentorial sinus are formed by the convergence of the vein from the basal and the lateral surface of the temporal and the occipital lobe. The lateral tentorial sinus arises within the lateral part of the tentorium and courses laterally to drain into the terminal portion of the transverse sinus. The medial tentorial sinus courses medially to empty into the straight sinus or junction of the straight and the transverse sinus. So this figure we have already discussed before. This is the lateral view of the posterior area, in which the straight sinus has been visualized. Also, this medial structure is the medial tentorial sinus, which open into the straight sinus, and these are the lateral tentorial sinuses, and this one is the medial tentorial sinus. Medial tentorial sinus open into directly into the straight sinus, whereas the lateral tentorial sinuses open into the transverse sinus and then into the sigmoid sinus. Other is the cavernous sinus. The paired cavernous sinus are situated on each side of the sella turcica and are connected across the midline by the anterior and the posterior intercavernous sinuses, which courses in the junction of the diaphragm sella with the dural lining, the sella. The anteriorly, each cavernous sinus communicate with the sphenoparietal sinus and the ophthalmic vein. Its middle portion communicates through the lateral extension on the inner surface of the great sphenoid wing with the pterygoid plexus, and small vein passes through the foramen spinosum and oval. The posterior cavernous sinus open directly into the basilar sinus, which site on the clivus. It communicates through the superior petrosal sinus with the junction of the transverse and the sigmoid sinus, and through the inferior petrosal sinus with the sigmoid sinus. So in this figure A, we are seeing the superior view of the floor of the middle fossa, in which we can see this white area is the cavernous sinus, paired cavernous sinus. Over here, the right half is right half of the dural surface is being excised, and we can see this blue structure which is opening into the cavernous sinus is the superior parietal sinus, which open into the cavernous sinus, and then we have the basilar sinus, in which the posteriorly the cavernous sinus is draining in, and below the cavernous sinus open into the uh, superior petrosal sinus, which eventually drain into the transverse as well as the sigmoid sinus. So superior petrosal sinus courses within the attachment of the tentorium to the petrosal ridge. It medial end connects with the posterior end of the cavernous sinus, and its lateral end join with the junction of the transverse and the sigmoid sinus. Its superficial vein, the superficial sylvian vein may empties into the infrequent tributaries of the superior petrosal sinus called the sphenopetrosal sinus. So in this figure, we can visualize the straight sinus, which is running backward, and these are the horizontal area, which horizontal structure which passes in the center is the transverse sinus, and then we have the S-shaped structure which is a sigmoid sinus. Over here is the apex of the petrosal bone, over on top of which is the superior petrosal sinus running on both sides. And as we can see over here, the cavernous sinus is also visualized, which is draining into the superior petrosal sinus. And over here we can also see the sphenopalatine sinus, which is opening into the cavernous sinus, and the ophthalmic vein opening into the cavernous sinus. So this is the base inferior view of the inferior surface of the brain, and over here the structure which is important to identify is the superior sylvian vein with over here, and the temporal basilar vein, which opens into the superior petrosal sinus. So and the figure D, we can visualize the superior petrosal sinus, which is running on the apex of the petrosal bone, and the red arrow, which is which signify the temporal basal vein opening into the superior petrosal sinus over here, which is posteriorly, and the anteriorly to the anterior in the petrosal sinus opens the superior sylvian vein. The superior sylvian vein open into the anterior part of the superficial petrosal sinus, whereas the temporal basal vein open into the posterior part of the superior petrosal sinus. After discussing about the dural sinuses and the lacunae, then we have the anastomotic veins. The largest vein on the lateral surface are the vein of Trollard and the Labe, and the superficial sylvian vein. The vein of Trollard is the largest anastomotic vein joining the superior sagittal sinus with the vein along the sylvian fissure. The vein of Labe is the largest vein connecting the vein along the sylvian fissure with the transverse sinus. Then we have the superficial sylvian vein courses along the surface of the sylvian fissure and drain predominantly into the dural sinus along the sphenoidal ridge. So in this figure, we can see there is a vein of Trollard, which is coursing from the superior sagittal sinus up to in the superficial sylvian fissure, and it communicate the superior sagittal sinus with the sylvian fissure. And over here in the lateral surface is we can see the vein of Labe, which connect the transverse sinus with the superficial sylvian vein. In this figure, there is variation in the as all these three veins are of equal size, but in some brain, some people, one vein is more dominant than the other. As in this figure, the vein of Trollard is more dominant, and a vein of Labe is smaller. In this schematic diagram, the superficial sylvian vein is more prominent than the vein of Labe and the vein of Trollard. And in this fourth figure, the vein of Labe is more prominent than the vein of Trollard and the superficial sylvian vein. The vein of Trollard is also called the superior anastomotic vein. Is the largest anastomotic vein crossing the cortical surface of the frontal and the parietal lobe between the superior sagittal sinus and the sylvian fissure. It is most commonly located at the level of the posterior post-central vein. The vein of Trollard usually joins the superior sagittal sinus as a single channel that is directed forward against the direction of the flow as it joins the sinus. So over here we can see the structure running downward, running upward from the superior sylvian vein up to the superior sagittal sinus is the vein of Trollard. It can be either single vein or it can be a double vein, depending upon the variation in the people. Then we have this structure which is horizontal, is the superior sylvian vein, and the lower is the vein of Labe, which connects the superior sylvian vein with the transverse sinus. So the vein of Labe is also the inferior anastomotic vein, is the largest anastomotic channel that crosses the temporal lobe between the sylvian fissure and the transverse sinus. It usually arises from the middle portion of the sylvian fissure, and it directs posteriorly and inferiorly towards the anterior part of the transverse sinus. It may cross temporal lobe as far back as the posterior limit of the lobe, or as far forward as the interior third of the lateral surface. So this figure, this is the lateral view, in which we can appreciate the two double vein of Tollard, and then we have the horizontal vein over here, which is horizontal. We have a Sylvian fissure, and in between, deeper to it is the Sylvian vein, superficial Sylvian vein, and then we have the vein of Labe, which is coursing posteriorly and inferior to the temporal lobe and joining with the transverse sinus. Over here, the posterior part of the temporal lobe have been elevated, and we can see the vein of Labe running posteriorly and inferiorly and opening into the temporal, the transverse sinus over here. Here, more magnified view of this area, and we can see the vein of Labe opening into the transverse sinus. Also, the posterior temporal veins are opening directly into the transverse sinus, and the occipital basal vein opening into the transverse sinus. The superficial Sylvian vein, which is the third anastomotic vein, the superficial Sylvian vein usually arises from the posterior end of the Sylvian fissure, and it courses anteriorly and inferiorly along the lip of the fissure. The superficial Sylvian vein receive the fronto-Sylvian, parieto-Sylvian, and the temporo-Sylvian vein, and are commonly in anastomosis with the vein of Tollard and the vein of Labe. It penetrates the arachnoid covering the anterior end of the Sylvian fissure and join to the parietal sinus, as it courses just below the medial part of the sphenoid ridge, or it may pass directly to the cavernous sinus. So over here in this is the lateral view of the left temporal frontal lobe, in which we can see the Sylvian fissure, and over the Sylvian fissure we can visualize the superior Sylvian vein and the vein of Labe, and these tributaries which are opening into the superficial Sylvian vein are the frontal and the temporal Sylvian vein opening into the superficial Sylvian vein. Over here we can visualize this area more prominently, as the lip of the upper and the lower lip of the Sylvian vein have been opened, and the frontal Sylvian vein and the temporal Sylvian vein are visualized over here, and as well as the superficial Sylvian vein. So the last topic is the cortical veins. The superficial cortical veins are divided into three groups based on whether they drain the lateral, medial, or the inferior surface of the hemisphere. The cortical veins on the three surface are further subdivided on the basis of the lobe and the cortical area they drain. The largest group of the cortical vein terminate by exiting the subarachnoid space to become the bridging vein that crosses the subdural space and empty into the venous sinus in the dural matter. The small group of cortical vein terminate by joining the deep venous system of the brain. So on the lateral surface of the frontal lobe is drained by the frontopolar, the anterior frontal, the middle frontal, and the posterior frontal, precentral, central, and the fronto-Sylvian veins. The lateral surface of the parietal lobe is drained by the central, post-central, and anterior parietal, the posterior parietal, and the parieto-Sylvian vein. The lateral surface of the occipital lobe is drained by the occipital vein. The lateral surface of the temporal lobe is drained by the anterior temporal, middle temporal, posterior temporal, and the temporo-Sylvian veins. The veins draining the lateral surface of the frontal lobe is divided into two parts, which is the ascending veins and the descending veins. The ascending vein drain into the superior sagittal sinus, whereas the descending vein drain into the superficial Sylvian vein. Whereas the ascending frontal veins are the frontal polar, the anterior frontal, the middle frontal, and the posterior frontal veins, and the precentral and the central veins. Whereas the ascending lateral frontal veins are the fronto-Sylvian veins. The vein draining the lateral surface of the parietal lobe are are divided into ascending veins as well as descending vein. The descending veins are draining into the superior sagittal sinus, where the descending vein drain into the superficial sylvian vein. Descending lateral parietal veins are the central, post-central, anterior parietal, the posterior parietal veins, and the vein of Trollard correspond to the large post-occipital vein. The descending lateral parietal veins are the parieto-sylvian veins. The vein draining the lateral surface of the occipital lobe are also divided into ascending veins and the descending veins. And descending veins are the occipital veins, whereas the few descending veins are ascending veins which drain into the superior sagittal sinus, whereas descending veins drain into the transverse sinus as well as the tentorial sinuses. So in this figure, we can see all the veins which are present on the lateral surface of the frontal, parietal, occipital, and the temporal lobe, which are draining into the superior sagittal sinus. And the descending veins are draining into the superior sagittal sinus, whereas the descending vein draining into the superficial sylvian vein. Also in the occipital lobe, the superior descending and the descending vein draining into the superior sagittal sinus, where descending veins draining into the occipital, transverse sinus, and the tentorial sinuses. In the temporal lobe, the descending veins draining into the superficial sylvian vein. The parietal area, the superficial sylvian vein draining the descending portion, whereas the ascending portion is draining into the superficial sagittal sinus. So on the medial surface, the frontal lobe is drained by the paraterminal and the anterior medial frontal, centro medial frontal, posterior medial frontal, and the interior pericallosal and the paracentral veins. The medial surface of the parietal lobe is drained by the paracentral, anterior medial parietal, posterior medial parietal, and the posterior pericallosal vein. The medial surface of the occipital lobe is drained by the anterior calcarine and the posterior calcarine veins. The vein draining the medial surface are divided into ascending as well as descending. The ascending veins drain into the superior sagittal sinus, whereas the descending vein draining into the inferior sagittal sinus on the medial surface. The descending veins, which are the medial frontal vein and the anterior medial frontal, the centromedial frontal, the posterior medial frontal, and the paracentral vein. The descending vein on the medial surface are the medial frontal veins, are the paraterminal and the anterior pericallosal veins. The vein on the medial surface of the parietal lobe are also divided into two, ascending and descending veins. The ascending vein draining into the superior sagittal sinus, whereas the descending vein draining into the vein of Galen and its tributaries. The descending veins on the medial side of the parietal lobe is the paracentral, anterior medial parietal, and the posterior medial parietal veins, whereas the descending veins are the medial parietal veins and the posterior pericallosal vein draining into the vein of Galen. The vein on the medial surface of the occipital lobe are also divided into two, ascending and the descending vein. And the ascending vein are opening into the superior sagittal sinus, where the descending vein draining into the vein of Galen. Descending vein on the medial ascending vein are the medial occipital vein is the posterior calcarine vein, and the vein draining into the deep venous system is the anterior calcarine vein. So this is the figure in which the medial surface of the hemisphere has been visualized, in which in this area we can see the anterior frontal, the medial frontal veins, which are draining, which are divided into ascending and the descending. The ascending portion draining into the superior sagittal sinus, where the descending draining into the inferior sagittal sinus. In the parietal lobe, it is also divided into two, ascending and the descending portion. The ascending portion is draining into the superior sagittal sinus, where the descending portion is draining into the vein of Galen and the internal cerebral vein. Where in the occipital lobe, the ascending and the descending portion, the ascending portion is draining into the superior sagittal sinus, whereas the descending portion is draining into the vein of Galen. And in the medial portion of the temporal lobe. We have also ascending and the descending veins. Descending veins draining into the inferior internal cerebral vein, whereas the descending portion is draining into the transverse sinus as well as the sigmoid sinus over here. So the inferior surface of the frontal lobe is drained by the frontopolar, the anterior frontal orbital, posterior frontoorbital, olfactory, and the paraterminal veins. The inferior surface of the temporal lobe is drained by the anterior temporobasilar, middle temporobasal, the posterior temporobasal, anterior hippocampal, uncal, medial temporal, and the temporosylvian veins. The inferior surface of the occipital lobe is drained by the occipitobasal vein. So the vein on the inferior surface of the temporal frontal lobe is divided into two. The anterior veins which drain into the superior sagittal sinus, and the posterior vein which empty into the anterior end of the basal vein. The anterior group of the inferior frontal veins are the anterior frontal frontoorbital vein. The posterior group of the inferior frontal vein are the posterior frontal orbital and the olfactory veins. The vein on the inferior surface of the temporal lobe are divided into two.
Dr. Oswin, we have to finish this. We are already late. Dr. Aqueel has to share his slides as well. So if there's anything else.
So just coming up to the radiology portion. In radiology, I have included few slides. One is for the MRV and the other is the DSA. So on MRV, we can visualize these veins. The most prominent and the large is the over here is the superior sagittal sinus. Over here is the this structure is the anterior cerebral vein. This area which is not clearly visualized is the inferior sagittal sinus, which opens into the vein of Galen, and over here is the internal cerebral vein, and posteriorly, as it moves downward, we have the trochlear of atrophyli, and then we have the straight sinus over here, which is running over here, and these are the transverse sinus, the sigmoid sinus, and the internal jugular vein. This was that was the lateral view, and then this is the posterior view in which we can see the these structure are the right and the left vein of Tollard. The middle structure is the superior sagittal sinus. The both horizontal structure are the transverse sinus, and as well as this S-shaped structure is the sigmoid sinus. So on DSA, these structure are also visualized very clearly. The most prominent structure is the superior sagittal sinus, and the vein draining into the superior sagittal sinus. We can see this is the internal cerebral vein, which is opening into the straight sinus. Then we have the transverse sinus as well as the sigmoid sinus over here, and opening into the internal jugular vein. So the posterior view of the DSA, in which we can see the straight superior sagittal sinus. We can this is the horizontal structure, which is the transverse sinus. Then we have the sigmoid sinus and the internal jugular vein. Thank you.
Thank you, Dr. Oswin, for the detailed presentation. Dr. Keel, can you please share your slides and your expert comments?
All right, thank you, Oswin. That was quite detailed and comprehensive. Let me see if I can do this quickly. I'm going to get back to work. All right, so yeah, so Oswin has really done a fine job describing all this, but I can tell you one thing for sure. Is the only consistent thing about the venous sinus anatomy is that it's inconsistent. I'm yet to see two patients and their angiograms where their venous anatomy looks exactly alike. And so, although it's important to know, obviously, the major sinuses and the veins, the superficial and the deep venous system, but at the same time, I think it's even more important to understand the vectors of the blood flow in them, because a lot of times in certain pathologies, especially in AVMs and AV fistulas, the flow is reversed. Those veins are arterial, and that will impact your decision making in terms of treating those patients. So, and as I said, as I was mentioning earlier, that the cortical veins, although there are several of them, and I don't think any of us, maybe except maybe Dr. Salmanshi, because he's been doing this for as long as I've been, probably remembers or you can name each and every vein, but most of us are probably not able to do that. So I think the important here is starting from the bottom is to be able to correctly interpret the vascular studies, and as Dr. Oswin towards the end alluded to the angiograms and the Emory and the CTV. Being a neurosurgeon just does not absolve us of not being able to interpret those images accurately, because neurosurgeons have to be excellent radiologists or neuroradiologists as well. And so I would urge each and every one of us to be very, we should be able to interpret those imaging, especially the angiogram, because those are dynamic studies versus MRV or CT, which are more static studies. Surgically speaking, in the operating room, you have to respect the veins a lot. I have worked at several institutions, and I've worked with several surgeons, and I have seen people where not respect veins, they just take bipolar and just coagulate them and go right through them. A lot of times, you can be lucky, you can get away with it because God has provided us with several collateral channels. But a lot of times, you might not be able to get away with it. You might, end up with a complication, as we will see shortly. And then it's important to understand the venous anatomy in several different pathologies like tumors, vascular malformations, in venous sinus pathologies, and then also when you're selecting a surgical approach, especially for skull-based cases, it's exceedingly important to know your venous anatomy. So I'm not going to elaborate. I'm not going to belabor all this. Dr. Osman had thoroughly gone through all these veins, as you can see. We talked about the trolar, the sylvian venous system, the deep temporal or the inferior temporal veins. You have the sphenoparietal sinus. Down here, you have cavernous sinus, and then eventually, obviously, you can see the suprachiasmatic sinus. And, you have some idea of the deep venous system, the intercerebral vein, and the vein of and the straight sinus as well. So as I was saying, obviously, no two venous angiograms or angiograms are alike. The venous anatomy can be very different. Here, obviously, you can see the trolar and the labes are dominant. Here, you can see a predominant diffuse labe, but really not a big trolar, and you have a lot of these other anastomotic draining veins. And so, obviously, the names will change. You can see here a frontal vein that's draining in place of trolar. But so it's obviously very important when you're, as I said, when you're dealing with a clinical pathology or operating on somebody. Another important point to mention here, as you can see, this is like an anterior cerebral vein. We talked about this vein of Labe, and a lot of times you can see as the veins enter the venous sinuses, you can see some constriction there. So you don't have to be fooled by that, because a lot of times people will try to stent it or try to open these up, and you can get into trouble. So obviously you don't have to, get very excited about that. This is a normal anatomical configuration, but that I thought was important to mention. Again, obviously, this is not an angiogram, so we're not gonna do that. Maybe hopefully at some point in time we can definitely dive into those details if you want. So important thing here is, these are a few examples from some of my cases, some of my cases of my colleagues, and obviously you can see on this angiogram, this was a parasagittal, like a frontal lobe tumor, like a deep medial frontal, that required an interhemispheric approach. And obviously, as you can see, depending on where you approach this tumor, you can see these veins coursing. Obviously they're coursing from lateral to medial. Obviously, you cannot appreciate that on a lateral angiogram. If you will see that these two veins are coursing from lateral to medial and then plugging into the superior sagittal sinus. So when you're gonna explore your interhemispheric picture, you got to be cognizant of these veins, and you have to try to stay posterior to them. And then at the same time, you have to be careful that when you start to retract your frontal lobe, that these veins don't get stretched and then rupture, and then the next thing you know, you're either you encounter a lot of bleeding in surgery, or patient ends up having a cortical venous infarct. So something to be careful about. So these are some pictures from the Neurosurgery Atlas. I'm sure you are all familiar with this website. If you're not, then I definitely encourage you to visit this website. It's called the neurosurgicalatlas.com. And you can, there are videos, lectures, there are presentations on there. I had the opportunity to write the volume of cranial nerve compression syndrome in this website. But the reason I picked up these pictures is to sort of depict pictorially how what I was referring to in the previous angiogram right here, like if you're trying to approach this tumor, and then you have a line which is right here, your superior sagittal sinus is going to be right here, as you can see, and the hemispheric fissure would be right here. But as you cut your dura and open it, you will see these veins coming in, and this is where, if you're not careful, you can easily, with your scissors, can across veins, or bipolar, then can lead to problems. So you sort of, if you have studied your angiogram preoperatively, you can anticipate the locations of these cortical veins and then preserve them, because anybody can cut these veins, reflect the dura, and take the tumor out, but the ability of a good surgeon is to anticipate the location of these veins and preserve them, obviously, to the best of your abilities. Sometimes you might not be able to retract the dura, and in those cases, sometimes you might have to just cut around the veins and leave a dural leaflet on top of these veins. Again, as I said, this website has a lot of these cool pictures that can help you understand, sort of, it's almost like a cookbook for neurosurgery. And I'm sure, when you're working with experts like Dr. Salman Sharif and Dr. Manzar and Dr. Saad, I'm sure they have seen enough of these situations that they can help you understand it. But I think mostly for the residents, it's exceedingly important to understand, anticipate, and then sort of, as you go on doing the surgery, the idea is not just to take the tumor out, but to be able to preserve all the normal venous anatomy, and then be able to take the tumor out, and then hopefully the anatomy will be preserved while then doing the surgical procedure. Similarly, if you're taking a tumor out, let's say out of the insula, let's say, obviously then you're having to work between the MCA branches in the candelabra, but at the same time, more superficial to that, you have this extensive array of superficial sylvian veins that Dr. Oswin was so beautifully showing us. And it's important to, as you can see here, it's important to preserve all those veins and sort of create windows above and below those veins to be able to take the tumor out. Obviously, this is a nuisance. It will be very easy to just buzz, coagulate, cut it out, get it out of the way, and take the tumor out. But that's just not right. As I said, sometimes you might get away with it, but a lot of times you will suffer the patient, not you, but the patient will suffer some serious consequences because of that, especially if it's the dominant lobe. So obviously, this is more painstaking, doing it like this, sort of creating windows. But once you get into a habit of this, then the operation will be much more elegant and safe. So, for instance, this is one of the cases where you had a tumor here in the precentral, sort of, I think, the supplementary or premolar area. And preoperative imaging, you can see that there's a small vein that's basically just on top of the tumor right here. It's a non-enhancing tumor, so you can see it on flare. And then postoperatively, you can see this vein sort of like preserved and sort of like sagging on the operative bed. The operative picture looks something like this. So, again, the tumor was here this picture is after the tumor was taken out, but the vein was draped right over the tumor, and it was very easy to just, you could have just coagulated this and cut this out and be done with it. And that could have been okay, but I think the beauty of neurosurgery is that you try to preserve this anatomy as much as possible. And so it's important to preserve, because the veins and the arteries are all running in the subarachnoid space, right? So this is where you have to know your anatomy. And so you can, what's called subpial dissection, remove the tumor from underneath the pia, try not to violate the pia subarachnoid plane. And then you can leave gel foam, which is soaked in heparin or heparin saline, or whatever it is to keep it moist, and so that the vein is not. The reason the gel foam is kept is because if you just take the gel foam out, the vein sort of gets kinked, like you can see here. If there's no support, the vein gets kinked. But if the vein is supported by gel foam, it's more straight and less likely to occlude postoperatively, and that's what you could see on the previous imaging right here. So important stuff. Again, as I said, some surgeons might disagree, but I'm a big proponent of saving every vein as much as possible. Obviously, there are some veins that you obviously have to sacrifice to move the operation forward. You cannot spend 45, 50 minutes just saving this vein and not taking the tumor out, because that would be also counterintuitive. This is one of the patients who had an aneurysm and needed a Sylvian Fisher split, and I'm sure most of you or all of you have done plenty of splits by now, or if not done and seen them. And in a lot of cases, sometimes you can see a rich Sylvian or perisylvian veins, and some of them, most of them can be mobilized most of the time temporarily, and you try to preserve them as much as possible. But if sometimes, as in this case, you take one or two of them and try to be, quick, then sometimes you can leave the patient with this picture, which is basically cortical venous infarct with some hemorrhagic version. This was on the right side, but if this was on the left side, patient certainly could have landed up with some speech deficits. So once again, it's important to study your preoperative angiograms or venous anatomy, and then proceed forward. In terms of other malformation, other pathologies like AVMs, you definitely need to know, and I'm sure as most of you are aware, what the AVM nidus looks like, what the draining veins are, superficial, deep, are they frontal, temporal, are they in front or behind? And this, for the most part, will guide your operation. Now, obviously, this is a big draining vein. As you can see, it's probably arterialized. It's more or less it's dysfunctional because it's not draining any normal brain. But obviously, you cannot sacrifice this vein at this onset of the operation, because this AVM obviously is getting a lot of arterial supply from the PL feeders, and then there's a high amount of shunting that's going to the vein. If you take this vein down, the AVM is going to explode, and then the next thing you know, you're the brain is herniating out at you, and you have to do what's called a commando operation to get the thing out, and that's not going to be eloquent. So obviously, if you have studied your angiogram carefully and in detail, you know that this is probably the last part of the AVM that you have to attack, and then you basically disconnect all the arterial feeders circumferentially before you occlude this vein. So again, this you could name this vein any way you want, like 6 ways to Sunday. It could be a medial, frontoparietal, whatever vein. But at the end of the day, if you take this vein, it's not gonna be a pleasant situation. Similarly, this is just one cadaveric picture of so when you're doing different approaches, most commonly, like let's say you're doing orthozygomatic or Tiriono or modified OZ, there are these like temporal veins that are draining into the sphenoparietal sinus, and they're always a nuisance because sometimes if you're really retracting the temporal lobe, you can just basically shear these veins off from the sinus and cause significant amount of bleeding. So again, as I said, when you are doing these approaches, you've got to be just cognizant of these veins and try to preserve them as much as possible. So this is a sort of an intraoperative view. As you can see the optic nerve right here, internal carotid artery. This is the right side, frontal lobe, temporal lobe. And you can see all these like temporal veins right here that Dr. Oswin was talking about. They're all going to sphenoparietal sinus right here, right? The sinus is within the dura, within the leaflet of the dura. So if you really want to get pretemporal, you might have to coagulate and divide these sharply. But if not, then if you just keep retracting the temporal lobe, like we're doing here, then you can just shear these off, and this can cause, so you got to be, obviously careful with that. Sometimes if you really need to mobilize the temporal lobe, but you would rather not take these veins down, then as is recommended in this paper right here, you can dissect the arachnoid around them, mobilize the temporal lobe and retract it to the best of your abilities while making sure that you don't, I mean, obviously that's more painstaking, but it's definitely safer and more elegant. Another important implication of especially the venous anatomy of the temporal lobe or the vein of Labbé is when you are trying to do an extended skull base approach, like this is the petrosal approach, like you would do sometimes, let's say for a large CP angle tumor or petroclival angioma. As you can see, this is a pre-sigmoid. So just to kind of orient you all, this is the mastoidectomy that has been performed here. Obviously, the semicircular lines are right here. This is your temporal lobe right here, and this would be the cerebellum right here. This is the sigmoid sinus, and the transverse sinus would be up here, so the transverse sigmoid. And you have the superior petrosal sinus coming right here. And so, as I'm sure you're all aware, in these petrosal approaches, you basically make two perpendicular cuts, one at the base of the temporal lobe and the other one in the pre-sigmoid area, which is the Trotman's triangle. And then you basically stop both these cuts above and below the petrosal sinus, and then you coagulate, divide, suture, ligate, whatever, the petrosal sinus, and you cut it, and then that basically opens this whole corridor for you. However, if you are careful enough and if you're a good physician, you are going to look at your preoperative angiograms to make sure that the vein of Labbe does not drain into the superior petrosal sinus, or if it does, because as I said, remember that there could be a lot of variations. If the vein of Labbe drains directly into the transverse sigmoid sinus junction, that's fine. But if it drains into the petrosal sinus and then that drains into the sinus, and if you have this right here behind it, the vein of Labbe will not have any drainage outflow, and then you'll have a massive temporal lobe infarct. And so, people will say, oh yeah, we did this approach and the temporal lobe started swelling and we don't know what happened. Well, what happened was they interrupted the venous outflow of the temporal lobe, and then the swelling happened. And so, as I said here, this is a great paper by Dr. Osama Al-Mehdi. As you can see right here, there are two different vein drainage patterns right here. You can see the vein of Labbe right here, and they see a small vein of Labbe right here. Now, this one, on more images, if you see, this one actually drains into the petrosal sinus, and then it drains into the transverse sigmoid sinus. So this case right here is not very ideal for petrosectomy, unless you decide to cut the temporary very anteriorly, which is painful. However, in this one, you do have some alternate pathways. You have a very small vein of Labbe, and this is something that you can potentially compromise in order to get your exposure. So as I said, obviously we're just flying through this right now, but it's very important to understand this anatomy and its clinical implications when you're designing your surgical approaches. And then very quickly, in terms of venous anatomy and the venous sinuses, the few times we encounter venous sinuses, one is very unfortunate when you can take a drill and open the sinus up and get a lot of venous sinus bleeding. But other than that, the other pathology we encounter most commonly as neurologists and neurosurgeons is venous sinus thrombosis. There's really no surgical intervention for that except for anticoagulation. Some people have started doing thrombectomies for that, but the results of that are very questionable. However, more recently, we have started seeing that patients who have idiopathic intracranial hypertension or pseudotumor cerebri have these pretty significant bilateral venous sinus stenosis. So you can see that right here, very focal stenosis right here. And data have shown that if there's a big pressure gradient across the site of stenosis, like by more than 8 or 10 millimeters of mercury. So if you stent this and you open this up, they get better with their symptoms. And I'm sure you all are aware how sometimes painful these patients, managing these patients could be with pseudotumor. But if you essentially put us, you can see right here, and open the sinuses, you can see the difference between the flow here and the flow here now after the stent was placed. They can get better. Actually, a lot of patients with pulsatile tinnitus have undiagnosed venous sinus stenosis, and that can get better. Again, I don't recommend that this be done as the first step in management, but I'm just trying to, sort of refer to the clinical implications of venous anatomy. So briefly, essentially, this is in a nutshell. I do have, some cases of AV fistulas, but I think we might be running out of time. But I'll let Dr. Saad, take it from here, and I would be happy to take any questions.
Thank you, Dr. Pabaney, for the excellent presentation and cases. Due to shorter time, we will not be able to take questions, but I thank you, Dr. Pabaney, for coming in and giving us your time, and we will bug you in the future as well for future sessions.
Sure.
Thank you. Thanks a lot.
Very much.
So I would like to conclude this session. As one of my mentors used to say, that good surgeons preserve arteries, but great surgeons preserve veins. Thank you all. We'll see you next week. Allah Hafiz.